All right, welcome back. This will be the video lecture for Chapter 21, Cardiovascular Disorders. So we have a lot to talk about, and so we're going to jump right on in. Let me introduce the chapter. The cardiovascular system transports oxygen, chemical messages, and that'll be in the form of like hormones, nutrients, waste products to organs designed to eliminate substances. Anything that might interfere with the ability of the heart and blood vessels to transport blood to and from the tissues can compromise the body function. So as an advanced EMT, you have to quickly recognize problems, provide prompt treatment. We have to have a good understanding of the anatomy and physiology of the heart, and also the pathophysiology of cardiovascular disease. Excuse me. You have to recognize, emergencies, specifically in this case, cardiac emergencies. You have to develop and implement a treatment and transport the patient to the appropriate facility. Let's look at the anatomy and the physiology review of the cardiac system here. The heart's located inside the mediastinum. The heart is a hollow muscular organ, and it has four chambers. The upper two chambers are called the atria, and the lower two chambers are called the ventricles. When we're looking at the heart muscle itself, we can look at the myocardium, and that's the middle layer. And that contracts due to electrical properties. We call those electrical properties automaticity. Then we have the endocardium, and that's the smooth inner layer of blood that flows through. We can look here at the position of the heart in the chest. The heart is just below the trachea, between the lungs and the upper half of the rib cage. The base of the heart is at the top, just below the main blood vessels leading into it. And the apex is at the bottom, just above the diaphragm. So it has a double-walled sac that surrounds the heart. The inner layer of that sac is known as the epicardium or the visceral pericardium, and the outer layer is known as the pericardium. And pericardial fluid allows frictionless movement of the heart, and I like to think of that layer. I don't know if you've ever seen like Italian sausage or something like that, but it's a very thin layer. Just looking at the heart, you really can't recognize it. But you most certainly can recognize it should there be fluid there. And then you would need a pericardiocentesis to remove that fluid. All right, and we continue here to look at the cross section of the heart. You're probably pretty familiar with this one. We have the superior vena cava here, the inferior vena cava here. We know blood comes into that. That's deoxygenated blood. It's represented by the blue here. Blood flows into the right atrium through the tricuspid valve into the right ventricle, through the pulmonic valve into the pulmonary artery right here and right here, where it goes to the lungs to be oxygenated. Once oxygenated, it comes back through the pulmonary vein into the left atrium here, through the bicuspid valve here, into the left ventricle, through the aortic valve, and then out the aorta to the body. The right atrium receives deoxygenated blood, as we just spoke about, from the systemic circulation via the superior and inferior vena cava. The left atrium receives oxygenated blood once it goes to the lungs and it's oxygenated. Both atria contract at the same time, and that forces blood into the ventricles. After a brief pause, these ventricles contract. They force blood into the pulmonary and systemic circulation. Oxygenated blood leaves that left ventricle through the aortic valve and then through the aorta. Deoxygenated blood leaves the right ventricle, and then there's the pulmonary artery, and then of course it goes to the lungs for oxygenation. There's 4 valves that maintain blood flow through the heart, and you have the aortic semilunar valve, the pulmonary semilunar valve, the bicuspid valve, and the tricuspid valve. If we look, and we can see the left and right coronary arteries, they branch off from the aorta, and that extends along the surface of the heart. We're talking about coronary arteries right now. Aortic valve opens during ventricular systole, right? So contraction, and that cusps over the opening of the coronary arteries. And that's important with when you have tachydysrhythmia rates to do limiting coronary artery filling time. So what it means is that when you get a heart rate above 150, 160, it's hard for the heart to receive oxygenated blood to distribute it through the coronary arteries because it's going so fast. During diastole, the aortic valve closes and it allows blood from the aorta to enter those coronary arteries. Here we have a view here of the coronary arteries here. It's your left coronary artery, your anterior descending branch right here. Here's your right coronary artery right there. So blood flows through the coronary veins. It empties into the right atrium. So let's look at ischemia. So any obstruction to the coronary blood flow deprives the affected area of oxygen. This ischemia can lead to pain, injury of the myocardial cells, infarction, or even death of that portion of the myocardium of the heart muscle. The blood vessels are known as the vasculature. There's 3 types of vessels. There's arteries, there's veins, and there's capillaries. Arteries are thick-walled vessels, and they're made thick-walled because arteries are normally under pressure, and they carry high-pressure blood that's leaving the heart. And as these arteries get smaller, they're called arterioles. And smooth muscle tissues allows them to constrict and dilate. Let's look at the capillaries here. Capillaries are microscopic blood vessels. They're single cell layer thick, right? And the reason why that is because inside the capillaries is where you're getting gas exchange, and we don't want those to be thick. We want them to be very thin, right? The diameter is just wide enough for that red blood cell carrying hemoglobin, carrying oxygen in a single file. And then we have veins. Veins contain valves that prevent backflow of blood. So, and occasionally when you're starting an IV, you'll hit one of these valves. And it's just an area of it's a valve that actually makes it the vein thinner. I guess thinner would be the right, maybe more constricted. Either way, they're used to help increase pressure to send that blood back up to the right atrium. Systemic circulation, that's through the aorta to the body, and then back to the heart through the vena cava. Here we have the blood vessel layers here. As you can see here, this is the lumen. Just on the outside, we have the tunica intima. Right here is the elastic, and part of the tunica intima is you have an elastic membrane. This is the smooth muscle that allows the vessel to constrict or dilate. And this very outside of the vessel is called the tunica external. All right. Just looking at some notes to make sure we covered everything there. Systemic circulation, so closer to the surface of the body, or peripheral circulation, is sacrificed during shock. The hepatic portal system, the bronchial arteries, but basically what it's saying is peripheral circulation, right? It has the ability of that smooth muscle to constrict, and when it does, it's moving blood away from hopefully the lower parts of the body that doesn't need quite as much blood. But the more shock you go into, the more it's going to constrict, and the harder it's going to constrict. And then we start looking at maybe sacrificing the kidneys, right? The kidneys seem to take a beating during shock because of the vasoconstriction that happens. Central circulation, blood in large arteries and supply blood to the internal organs. Then we have pulmonary circulation, and this is the pulmonary veins and the pulmonary arteries. Let's take a minute to review the components of blood. We have white blood cells, right? We have red blood cells, and then we have platelets. These monocytes and eosinophils, the basophil, the neutrophil, the lymphocytes are all white blood cells. And they just have different jobs to fight infection and to fight infection, fight viral things, to recognize pathogens, and to develop antibodies. Right here, you have this test tube here. We can see that we have electrolytes, enzymes, fat, proteins, and carbohydrates. This is a diagram of the test tube. It shows the red blood cells are 45% at the bottom. White blood cells and platelets make up about 1%. Hang on, make sure I'm reading this right. So it's saying 45% at the bottom, white cells and platelets, 1% at the center, and plasma, 54% at the top. So, and that makes sense because here you have 54% is plasma, which is what? Mostly water, right? With some proteins. And then 45% red blood cells. And then 1% here of your white cells and platelets. So when we talk about blood, we're talking about plasma, red blood cells, white blood cells, and platelets, like we just talked about. When we're talking about perfusion, so perfusion depends on adequate blood pressure. And so remember what blood pressure is, right? Cardiac output equals heart rate times stroke volume. And so if you, let's see here. I'm not a big math guy for sure, but it does kind of help me to think about it like this. Oops. You have cardiac output. Oh, Lord, hang on, back up. If it's going to let me do it. We'll see if it'll let me do it. See if I can get my pen to work. Anytime you can mess with this equation, you're going to be messing with blood pressure, right? If I can get the heart rate up, blood pressure is going to go up. If I can bring the heart rate down, blood pressure goes down. Well, same for stroke volume, right? Anytime that if we can encourage a vessel to dilate, blood pressure is going to go down. If we can do anything to reduce preload, blood pressure goes down, right? So that's what we're constantly doing with blood pressure, depending on the patient's needs, is we're doing something with this equation. All right. And so what this is a representation of is it's talking about pulmonary circulation, right? And so we know that we have here these red blood cells that are coming down. And we know that here's your alveoli. This is your capillary. There's very little room in between, right? Remember, these are 1 cell thick for that reason. And you're going to have the alveolus dropping off oxygen here through diffusion, right? O2 wants to come here because there's not a lot of it. And then it's going to pick up CO2, carbon dioxide is going to transfer out of here into the alveolus. Why? Because there's not a lot there, right? And then up and out. This is pulmonary circulation. Well, this is systemic circulation right here. And the same thing happens, except we're just feeding the cell at this point. We're going to pick up the dirty waste products of the cell called CO2. It's going to come into the plasma and the red blood cell, right? And the red blood cell is going to drop off oxygen to the cell to feed the cell. We talk about cardiac output and blood pressure. Systolic blood pressure, the normal range we kind of like to be around, right? Per American heart, 100 systolic to 140 systolic. And if we look at diastolic blood pressure, 60 to 90. Right, that's where the body likes to, inside that pressurized system, that's the pressures that the body works the best at. Anything above 140 would be considered hypertension. And when we start talking about anything below 90, we normally call that hypotension. If we look at the electrical activity of the cardiac cells, that leads to mechanical contraction of the cardiac muscle. And that's why cardiac cells are specialized, just through automaticity, right? That is their specialty, is to be able to fire off that electrical point to allow the heart to contract. Electrical activity conducted to the surface of the skin, it can be detected by electrodes. And that's how we use the cardiac monitor to read that ECG. So types of cardiac cells. Well, the pacemaker, we like to call that that automaticity of the pacemaker cells. Conductive and contractile cells that provide that mechanical contraction. And that electrical stimulus, well, it begins at the, right here at the SA node. So with the SA node, the electricity travels down to the AV node, right? Where it then goes through the it goes right before it gets to the AV node, it goes through the AV junction, AV node. Then it's going to branch off. It needs to fire these ventricles off, right? Because not only do the atriums contract through electrical stimulus, but so do the ventricles. And that electricity branches off here at the bundle of His, and then it's going to go to the left and right sides. And it provides that. These are called Purkinje fibers and the Purkinje system. And, you know, I remember when we didn't even talk about the Purkinje system, we just talked about the Purkinje fibers. And that's all these are, really. You don't have to get confused with all the names that they want to add to it. electrical impulses that go through the heart base on flow of ions through channels and cell membranes, right? And so, again, we're talking about the cell. We're talking about those places at the channel where they interact with these ions, positive charge ions and a cardiac function. Remember what positive charge ions are too, and we talked about it a little bit. We know that when we deal with sodium, well, it's a positively charged ion. A big one here, potassium, positively charged ion, right? Calcium, positively charged ion. So all of those work to bring that negative charge ions in the cardiac function. Chloride, all right, that's a negative charge ion. So we've talked about AEMT, about depolarization, right? That's positive charge ions flow to the least positive area until the difference between the two becomes zero. Remember, so we have that sodium rushing in to the cell, calcium's holding the door, potassium's in there, and that's where all change of the cell occurs inside the cell. And so you get depolarization. Repolarization is a difference in charges restored. ATP is required to translocate sodium and potassium. And that all that's talking about there is that, remember, both of these are positively charged ions, right? So we have the cell here. See. So you have potassium, sodium, and who hangs out with sodium? The freshman, right? But notice they're all positively charged, right? And so sodium really doesn't want to go inside, and so it's going to need to be forced inside that cell, right? And so we do that through the sodium potassium pump, right? And so something's going to have to push sodium inside that cell. And you have your sodium potassium pump right there, right? And so it requires energy. It's not diffusion at this point because there's plenty of positively charged ions in there through potassium. So sodium's like, I don't really want to go in there because there's already positively charged ions in there. And so something's going to have to force that to happen. And so that's going to require energy, and that's the energy you get through ATP. That's why metabolism is so important, right? Because if you need aerobic metabolism, because anaerobic, what do you have? Well, anaerobic, you have less energy, you have less ATP, right? You don't get the water and you don't get the heat. And so that's super important. And then we can look at the waves on the ECG that represent depolarization and repolarization. All right, so we can look right here. This is your P wave right here. And all right, so this is your P wave. Let me get it right. And so the P wave, and that's represented by this little hump right here, right? And that is called atrial depolarization. Right, that's when everybody gushes in. We also look at it like the firing. That's what causes that first bit of electrical activity to start moving through the SA node. This is ventricle depolarization. So this is the actual firing of the ventricles. And then when sodium starts going back outside the cell, and calcium's holding the door, and then the calcium joins back up with sodium. That's ventricle repolarization. That's that moment of rest to allow everybody to reset themselves in that process. So the SA node is we call it the pacemaker of the heart. When it's working, we should see a rate somewhere between 60 and 100 beats per minute. Now, if something happens to the SA node, for some reason, the SA node doesn't fire, the backup system here called the AV node will fire, right? And so the only problem with that is the rhythm's not going to be as smooth. It's going to be a regular to irregular type rhythm. And our pulse rate could change too, depending on what's going on with the heart. It could be anywhere from 40 to 60 beats per minute. And then we get here to the Purkinje fibers. And you see where it says it has an intrinsic rate of 20 to 40 beats per minute. Right, so here we are here with these fibers. So if our SA node's not working and our AV node's not working, then we get into these firing. And when these guys are firing, it's so irregular. It's a very irregular rhythm that can lead to dangerous type rhythms like VFib right here. So if this is all we have working for us, it's usually not that great. Now, believe it or not, you can have patients like that in VTAC, and they're maintaining some sort of blood pressure through this. It's really crazy. It won't be a great blood pressure, but you'll notice it at times where they'll have they'll still be hypotensive. A lot of times super hypotensive, but in the early stages of VTAC, that's why we'll elect sometimes to give medications for that and instead of shocking them. But anyway. Again, we talked about the P wave. There's a PR interval, a QRS complex, and a T wave. So if you look here, right, this is your PR interval right here. Then we have the QRS complex, which is right here. And then this is considered the T wave. And this is normally what we look at to represent a ST elevated MI, because a lot of times if the heart is damaged, this will start to go up. And we look at the boxes, and if it has more than 3 boxes up, then we can consider that a STEMI. Now, a lot of times we have something called an NSTEMI. So after the acute phase of an MI, sometimes we can start seeing old damage because this will deflect downward. We've talked about 12 leads. It's inside your scope of practice to be able to place a 12-lead EKG. You can't interpret it, but you can read it. You can read the top of the interpretation. And if it interprets, star, 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 ST elevated MI suspected, then, we can all figure that out, right? It's not hard. Then you have somebody experiencing an ST elevated MI or a STEMI. 12 lead allows for that recognition of ischemia or infarction events. That's what I'm talking about. And not all patients with acute coronary syndrome will have a STEMI, right? You can have patients who are very symptomatic of cardiac related emergency, and they may not show ECG changes, and not every STEMI shows ECG changes. Roughly 80% of patients having MIs will represent that on the ECG, but 20% of those do not. And we had to pick it up through testing the cardiac enzymes. This is just about accurate 12 lead placement, making sure you have good contact with the skin, making sure that the skin is dry. Use a 4x4 if they're diaphoretic to draw, to scrub that skin a little bit before you place the electrodes on. This is what they call bipolar lead placement. And what it's rated is right arm is a negative, the left arm's positive, and then positive left lower. And that's how it reads through the electricity. If you look here, like V1, and this is going to go through exactly where you're supposed to put them. Let's just be honest. You can be off a little bit and still get an accurate ECG. If you're, let's say I'm up here and up here, right? I'm probably not going to miss a STEMI if it's off by the intercostal space. Where that gets important though is when you're like Bill Lillard and you start reading EKGs like a cardiologist, and you're looking at a bunch of different stuff, then placement can be very important. So we're talking V1, fourth intercostal space, V2. You can read this. I'm not going to sit here and read it to you. You can read it. This is a normal sinus rhythm. I'm sorry, I'm getting it's 7:37 a.m. on Wednesday morning, and there's a bad wreck on 285, and I'm just getting all kinds of text on it. All right. If you look here, this is a normal sinus rhythm because it originates in the SA node, and we know that it originates in the SA node because of that P wave. That P wave recognizes that it's firing from the SA node. When we're talking about general assessments of cardiovascular complaints, it says clinical reasoning, develop a list of differential diagnosis and field impressions, right? And so what we're talking about here is, there is a lot of reasons for people to have chest pain. Some of those are related to cardiac related emergencies, but some are not. Like if I pull a muscle in my chest, well, I'm going to have chest pain, and maybe I've been lifting weights, or maybe I picked up the kid the wrong way, etc. And I pull a muscle in my chest. Well, that's muscular type chest pain. We have to be able to recognize that, and we can through taking a good history. Asking the patient, well, when did this start? What were you doing when it started? What does it feel like? Right? And then we can do an exam, and we can actually palpate the chest. And if usually cardiac related chest pain, if you palpate the chest, it doesn't change the pain, right? But if I have a sore muscle in my chest and I palpate that chest, obviously it is. And so a lot of respiratory complaints, a lot of pleuritic complaints, right? Or maybe I'm suffering a pneumonia or something like that. And so when I take a deep breath, my chest hurts really bad, but it only happens when I take a deep breath, right? You get where I'm going. We have to, because now you can give you can give nitroglycerin, and we don't want to be spraying nitro or giving nitro tabs to everybody who says my chest hurts. We have to be able to make a good good clinical diagnosis of why we're giving what we're giving. And so again, that comes from chief complaint. We can obtain a history, vital signs, right? And then perform a good physical exam. Vital signs tells you a lot, though. I mean, like if I'm trying to rule out congestive heart failure versus asthma, my patient's super hypertensive, I'm going to bet the farm that it's going to be CHF related and not asthma related. Obviously, we're going to assess the airway. If the patient's unresponsive, we're obviously going to resuscitate that patient depending on what's going on, right? The quicker we can get an AED on, the better CPR we do with good deep compressions that are fast. We have a much better chance of resuscitating that patient. And then we have to recognize that, to be able to differentiate respiratory distress from respiratory failure. So what are we looking for when we're talking about these complaints? Well, onset, right? Provocation, the quality, the radiation, the severity of the time. We're looking at symptoms, allergies, medications, past history, right? Because are these patients taking something for their hypertension, right? Are they taking them the way they're supposed to take them, right? Are they compliant with their medications? These are all kind of go with cardiovascular complaints like chest pain, shortness of breath. Sometimes they'll describe it as a heaviness, or pressure or discomfort, and indigestion. Sometimes they'll have abdominal pain, back pain. And I want you to also remember the differences in cardiac related chest discomfort between males versus females. Females, most of the time, are not going to have typical chest pain. They're the ones that are going to complain of abdominal pain or back pain, or I don't know about headache. They may call it a pressure or discomfort, right? Because that's why death rates for females in heart disease are much higher than males, because males are lucky enough to get that sudden onset of severe chest pain, radiates into the left arm, into the back. Males are usually, if we have that. Females do not. I remember as a young paramedic having to resuscitate a female patient because her complaint was, I have a pressure in my throat. And I missed it. I didn't know she was a cardiac patient. I thought she had something going on with her throat. Now I'm so much more keen to listen to complaints of everybody. And really listening. You have to really listen and look at your patient. So a lot of times these complaints come in as palpitations, but a big one here, especially in females, is syncope. Anytime if you're dealing with somebody who's a cardiac age, and it goes with males too in this, and they have a syncopal episode, you need to do a 12-lead EKG. You need to do a 12-lead all day long, because a lot of times cardiac events can cause syncope. And altered mental status, yes, nausea, vomiting seems to go with it, and God forbid, cardiac arrest. So let's talk about acute coronary syndromes. These are caused by insufficient supply of oxygen to the heart. And so what we're looking for is your patient, we'll call it maybe unstable angina. We can't rule out acute coronary syndromes do include acute myocardial infarctions and sudden cardiac arrest. So atherosclerosis The 4 stages of development of atherosclerosis are shown in this diagram. All right, and so here we have a damage to the endothelium, and the damage is because plaque buildup. And if you can really look there, what's that on top of that plaque? It's platelets. Well, maybe it's not. Maybe just showing the endothelium. But you got to worry about platelets piling on top of this too. Right? So this is how fibrous plaque forms. And so the fatty streak forms here. It just keeps growing, gets getting smaller. And blood has to go through this, right? And it gets larger. Now, when this plaque ruptures, see the red? Now that's platelets right there. That's your platelets. So what affects it? Well, genetics, right? An inflammatory response, smoking, diabetes, and hypertension. The inflammatory response comes from the body. You can think of like allergic reactions, things like that. Not an anaphylactic reaction, but more or less still a reaction to something environmental a lot of times that'll cause a buildup of this. All right, disruption of the endothelium tunica intima causes a damage to those endothelial layers that allows the lipids or fat to enter and accumulate in tissues beneath the intima, and because it's seen as a foreign invader. And because of that foreign invader status, now plaque, it comes, or you have your platelets that's coming around. Plaque narrows the coronary artery around the lumen, and the rupture of the plaque leads to acute myocardial infarction. Angina pectoris, right? And so this is because of probably of a atherosclerosis type development, because now the vessel's smaller, and when you add workload to the heart, like at rest, you don't have any pain, but now you go to climb some stairs and you put more of a workload on the heart. It needs all of the diameter of the vessel when there's a workload to send all the blood to the heart muscle. When you add that workload, it needs all of it. And so you walk up the stairs to do the laundry or whatever, and then this pain happens. And it's cardiac chest pain. It's just like a heart attack. Pressure, tightness, it radiates to the neck, jaw, left arm for males. Females could be abdominal pain, dizziness, nausea, a heaviness that transfers to the back. You know, we can't forget to leave them out. I mean that because it's so important. You can have nausea, vomiting with this, that pallor color that I like to describe so much, the diaphoresis, all of that can occur with that. These are areas of what they call early signs of acute coronary syndrome or heart attack, epigastric pain, mid-sternum chest pain, back pain, a wider area, etc. But yeah. Now, if stable angina comes on only during exercise or stress, and it resolves with rest or nitroglycerin. And so what I just described earlier with that angina event, well, that's the beauty of it. If you get up there to do the laundry or whatever, and this happens and you sit down and you go, oh my God, I think I might be having a heart attack. And you sit there for a minute and you're like, I think I'm going to call 911. Then it starts getting a little bit better. Oh, it's getting better. And then you start coming up with excuses. Well, I think that was the worst indigestion of my life. I really do. I got to, whatever. Well, that's stable angina. Unstable angina, though, if I continue, so, I go about my life. I chalk that up to that. And then 2 weeks from now, I go back up there to do laundry. Same thing happens again. This could be called unstable angina, because now, as I'm just hanging out, not walking, not doing exercise, the chest pain happens, and that's why it's unstable, because that coronary artery is getting more blocked, and now it doesn't take as much for that pain to come around. The unstable one can lead to AMI, acute myocardial infarction. That unstable angina can, because you have such a narrowing coronary artery. And so the problem with a myocardial infarction is tissue death. We have a lot of great treatment now for heart attacks. You get to the hospital. Let's say I've been hurting. I was hurting yesterday really bad. And I waited. And now, today I decided to go to the hospital, 24, 48 hours later. We still have good treatment. We have good blood thinners. We have lots of good meds. The problem is that heart tissue is never coming back. It's dead. And so now I'm having issues with what? With the heart contractions, right? My heart's not strong enough to contract to send blood up and out the aorta, right? And so now I'm a big risk for heart failure, right? Because blood's going to back up into the lungs, right? And so now I have to have a nasal cannula. And when I walk to the mailbox, I'm having to stop because I can't make it there without being winded. The quality of life's over. I can't be walking on the beach with the grandkids. I can't go out. I'm attached to an oxygen tank all the time. I've got to take 14 different medications just to help the other piece of heart muscle that's not dead to be able to contract harder and stronger. So that's why we make such a big deal about, as soon as we can, recognize that someone's having a heart attack or a STEMI, to get them to the appropriate hospital, not DeKalb Medical Center, Hillendale, not Rockdale, right? But no, to like a hospital that's PCI, that has access to a cath lab 24/7. You have access to cardiology 24/7, to be able to go in to do stents or even open heart surgery if needed in order to save the heart muscle. So here's acute myocardial infarction. This is when it can occur at rest. It can occur during exercise as well. It can occur as unstable angina as well. But either way, the difference here is that we actually have tissue that's beginning to die. And the pain that you're having is related just to that. It's related to tissue that's ischemic, that's either dying or is dead. And that's why we have to act fast. We've talked about the signs and symptoms of angina. We're going to talk about the same signs and symptoms for MI. But there is such a thing as a silent MI, right? Where patient doesn't have any pain. Maybe they don't have the body doesn't use the pain sensory as well, and they don't have pain. And we call that a silent MI. They may have other symptoms though, like hypotension, diaphoresis, things like that. Here they break it out between angina pectoris versus myocardial infarction, and like the first three, same. I don't really think, and I don't really care. And I don't think you should either, really. When it comes to being able to tell the difference, we need to treat this patient as if they're having a heart attack, right? If they get better with our nitro and it goes away and they live happily ever after, great, right? But we don't need to get conditioned to think that that's going to be the case because most of the time, quite honestly, it's not. But let's look at some of the differences. Dull or heavy discomfort with a pressure squeezing sensation. The myocardial infarction says, yep, same, but more intense. All right, so usually 2 to 15 minutes, and then it stops. And then we can look at MI. It says, well, longer than 10. They're saying that the MI patient's going to look worse. They're going to be pale, gray, nausea, weakness, dizziness, lightheadedness. Nitro here can give complete relief, but nitro in the MI may give relief, but not complete relief. So atypical presentation of ACS. So pain in the back, arms, or jaw, indigestion or abdominal discomfort, nausea, vomiting, fainting, or faintness. Pay special attention to that, and weakness. And so when we're looking at this slide, just because you get dispatched to a chest pain call doesn't necessarily mean you're dealing with a cardiac event. So you always have to keep an open mind and be a very good critical thinker to think about exactly what you're dealing with. Because we can have the patient who's having chest pain, and it can be heart failure. So it could be difficulty breathing along with chest pain. Or you can have the patient who's in failure and the only complaint is respiratory distress. Always consider getting that 12 lead done quickly. Anybody with myocardial ischemia has an increased risk in cardiac arrest, right? Depending on, especially like if you're dealing with someone with an inferior MI, where that heart damage is over the pacemaker parts of the heart, and you start having problems conducting electricity down through there, then you definitely can increase the chances of death in that. Risk factors for MI, hypertension, diabetes, patients with high fat or lipid levels, obesity, someone who smokes, family history, or a history of coronary artery disease. Nothing new there. This is talking about the assessment stuff, and let's talk about the transport. Remember, let's transport these patients to the appropriate facility, right? Again, if you have someone who's showing STEMI on your 12 lead, please take them to the appropriate facility where their quality of life can be much better after they get out of the hospital. So again, let's talk about oxygen. We want to provide oxygen if they need it. If they're satting at 94% or below, and some books say 92% or below, then provide oxygen. They're looking at that free radical theory, right? And so they're saying, well, free radicals, like, if 2 molecules of oxygen is normal. Well, in a free radical, you actually are holding on to 3. It's called O3. And that's a problem. And that free radical theory, they say is super bad, provides, all kinds of chemical reactions in the body and can lead to cardiac arrest, can lead to further heart damage, can lead to more vasoconstriction, right? Free radical theory. And that's where they're at. But I'm going to tell you this. If you feel like your patient needs oxygen, give them oxygen. Because we do want to respect that theory, but at the same time, if you think they need it, they probably do. Right? So if they show signs to you that they're hypoxic, I'd rather give them oxygen than think about a free radical theory, right? Let's give them that aspirin. It's if there's no contraindications. Remember, aspirin was on its way out the door. Aspirin had no place left in the medical community. It was gone. And till we found out what a great platelet aggregator it is. And when they did those studies, you know, they used 162 or 281 milligram baby aspirin, and man, they started seeing lives saved. It's super important that you give them that aspirin, the baby aspirin, the 324, and that they chew the aspirin, not swallow it. Because the chemical reaction that we need for the maximum platelet aggregation comes with that baby aspirin mixing with saliva. So super important that they chew it. If they taken some baby aspirin prior to your arrival, and they took it and they swallowed it, they didn't chew it, and they're having a STEMI, give it to them anyway. Give them. It's not going to hurt them. It's not going to hurt them. Remember, it's not a blood thinner. It enhances platelet aggregation. Okay, don't worry, you're not going to bleed them out. All right, you're going to start an IV. Super important here because these patients are, if they're STEMI patients, they're high risk for death. Right, they're high risk for cardiac dysrhythmias. Let's get the IV started while they're, before they get there. It's much easier for IVs on people that are alive and then dead. And what does that allow for? Well, if you called for an ALS unit, where you're going to be an ALS unit, you call for a paramedic unit, it allows them to be able to have access to push anti-dysrhythmic drugs or life-saving cardiac drugs should you need it. Let's give them some nitroglycerin as long as their systolic blood pressure is over 90. Right? Let's give them the nitro. If you have a patient with an inferior MI, make sure they have a decent blood pressure and make sure they have a decent pulse rate. I know a lot of it's they say nitro is contraindicated in inferior MIs. Well, that's great. But it's hard for you guys to recognize that you have an inferior MI. So the only thing I ask is just to make sure that they have a good pulse rate and they have a good blood pressure, and you got some fluids hanging. If they lose their pressure, bolus them. You can provide analgesics if protocols allow, right? I don't think our protocol allows to give Toradol for a patient with chest pain that's cardiac related. But anyway, this tells you the like I said, when they did the studies, they did 162. But somebody thought, well, if 162 works, maybe 324, 325 will work. But either way. Here's nitroglycerin. There's your side effects. They want you to obtain venous access first. Why? Well, if you have an IV and the patient blood pressure tanks on you, you have a way of bolusing them with some fluid to help. But what I would like to tell you is that patients out in the field are prescribed, or patients in general, citizens are prescribed nitroglycerin. And they're not starting their own IV, are they? Right. And so they're not. And so they take nitro. It's fine. It really is. Don't hold off nitro because you can't get a line. If you have a decent blood pressure and a good pulse rate, go ahead. Let them have their nitro. Don't wait because you can't get a line. It's ridiculous. It's how the medical community gets tied into this. I don't know. And if we carried nitrous oxide, we could load them up. But we don't carry it. So here, this book, if it's less than 94%, go ahead and start a nasal cannula, 2 to 4 liters per minute, and move up from there should you need it. Sudden cardiac death and cardiac arrest, right? So lethal cardiac dysrhythmias can occur as first indication of cardiac artery or coronary artery disease. And there's a VFib. VFib is a cardiac rhythm, and this cardiac rhythm usually has no cardiac output, right? VTAC does, but VFib was what we're talking about, so it doesn't. The only way to reverse VFib is to defibrillate them. So get your AED out, put it in AED mode, and VFib will transition into asystole without proper management. Asystole means without contraction, and that is your solid flat line. Asystole, if present, is more so an indication of untreated dysrhythmias and or prolonged cardiac arrest. True. So if you get there and the first rhythm you see is asystole, a very little chance you're going to get that patient back. And on the rare chances that you do, chances of keeping that patient alive and seeing them discharged is very little. Very small. Very, very small. Here is your VFib. And so look at that. It's unorganized rhythm. And let's see. I'll show you. Just got to back up. And let me show you something. If I can find it. I just got to find that slide that we looked over a minute ago. Right here. VFib's happening right here. Right, the SA node's not working, the AV node's not working, there's no bundle of His, and these individual cardiac cells are firing down here at will. There's no organization to their firing, but they're firing. And what are they trying to do? They're trying to stimulate these ventricles to contract. And since it's surrounding the ventricles, that's where you get the name VFib. These guys are down here shaking. There's no atrium activity going on. It's both ventricles that are happening. So we're familiar with AEDs. We know that that is the cure for this. We're going to put them on the AED and we're going to shock them. Asystole is the absence of contractions. A without, systole contraction. Let's talk about some of the possible causes of cardiac arrest, because, cardiac arrest is not always from a heart attack. You can get there because of just really bad metabolism, and aerobic metabolism can lead to cardiac arrest. Here we have hypoxia being one. Hypovolemia. Someone who's, like I just said, just they're acidotic, right? Excuse me, let me get a drink of coffee. One sec. Hypoglycemia, hypothermia, someone poisoned or overdose, attention pneumothorax, right? Just a type of shock, right? Tamponade, a type of shock, thrombosis, so a pulmonary, like a clot, or trauma. So some of these we can work to help, like hypoxia. We can ventilate the patient. Hypovolemia, right? Well, we can't replace red blood cells, but we can replace volume. So let's start a fluid bolus on these patients, right? Someone who's acidotic, not a lot we can do as an advanced provider. Hypoglycemia, we can check their sugar, and if their sugar's low, we can provide some D10. Hypothermia, well, we can warm them up. Toxins or tablets, poisons or overdoses. Yep, we know we can, opium overdoses can lead to cardiac arrest. So let's provide some Narcan. Attention pneumothorax, not a lot we can do as an AEMT for that, but we can start thinking about getting them transported rapidly or meeting up with a paramedic who can do a needle decompression. Cardiac tamponade, not a lot we can do with that, but the surgeon can. They can do a pericardiocentesis. Thrombosis, right? So these are the ones that you feel really bad about, especially those pulmonary embolisms, because when it happens, unless I don't know, even if they go into if they catch them in something called a peri-arrest state right before they go into cardiac arrest and they can get them to a vascular interventus, then yeah, they might live. Other than that, they're going to die. There's not enough time to deal with it. And then obviously trauma. We talked about heart failure. We'll kind of go over it again. Heart failure is an end-stage result of many cardiac diseases. We talked about that. Like heart failure is going to occur, right? Because, a lot of times you have damage to the heart and you've lost your ability to contract. And then there's coronary artery disease. Occurs as a result of impaired pumping capability of the heart. I just said that. So left-sided heart failure causes pulmonary edema. Right-sided heart failure causes peripheral edema. And then right side usually leads to left side heart failure rather quickly. The most common cause of right-sided heart failure is, here we go, left-sided heart failure. And the cor-pulmonale right-sided heart failure occurs from increased resistance in lungs. Let's look at this left-sided heart failure. And so signs, cyanosis, tachycardia, noisy labored breathing, rales, coughing, blood-tinged sputum. It's that pink sputum too. And tachycardic rhythm, and just marked shortness of breath. Damage here to that left ventricle. It's backing up into the lungs, causing the problems. We can look for the neck vein distension. We can look for lower extremity edema. We're not going to pick up an engorged liver. And sometimes something called ascites, which is abdominal distension. Kidneys here become hypoperfused. Water is further retained in an attempt to increase blood pressure. Remember Frank Starling's law. The greater the stretch of the myocardium, the greater the force, the heart will contract. This only works to a point. Past that, increased venous congestion occurs. So how we're compensating for this? Well, chronic vasoconstriction and tachycardia. We're pumping against a really high pressure. We're trying to pump against a damaged heart. And so the myocardium is increasing. Everybody's trying to work harder to compensate for that. And it can only compensate for so long before it starts failing. You can go through here, this table 21-2. You guys can look at that. We cover one of these. If you're watching this before Wednesday night, then you'll get to see one of these. But we're going to deal with heart failure in the classroom as part of a scenario. All right, so let's talk about your heart failure patients and how to treat them, right? As soon as you notice this heart failure, and the book teaches a lot of different things. The book's going to tell you, well, look for neck vein distension. If they have a really short neck, you're not going to be able to see that. The book's going to tell you to listen for lung sounds, and you should hear rhonchi or rails. Well, if they're not moving enough air, you're not going to hear that. Book's going to tell you to look below for peripheral bilateral lower extremity edema. Some of your patients that are large, you can't see it. So what are you left with? Well, you're left with blood pressure. And especially if you're trying to determine the difference in someone with an asthma versus CHF or COPD versus CHF. And the blood pressure will never lie to you. If that patient's super hypertensive, 180 over 110, 200 over 122, just treat them for congestive heart failure. You will not go wrong. Will not go wrong. So the beautiful thing about it, though, is we can use CPAP for both asthma and congestive heart failure. So you get there, you recognize someone who's in moderate to severe distress. I usually get a blood pressure really quick, and then I start working from there. I'm going to go CPAP first thing. I'm going to go CPAP. My second thing that's coming out of my bag is the nitroglycerin. So I'm going to provide some nitroglycerin. Why? Because I need to reduce the preload. I need to open up the vascular. Nitro is a potent vasodilator, and it's going to allow that fluid into dead space of the lungs, gives that fluid somewhere to go. Got about 200 milliliters of dead space. We're going to open that up, and it's going to allow that fluid that's hanging out in the alveoli to move down to that dead space. So we're going to do that. And then we're going to start INT so that we have a drug route in case this patient's prolonged hypoxia leads to cardiac arrest, or leads to a situation where we need to get ALS in there to provide IV medications. We're talking here about cardiogenic shock. So someone in cardiogenic shock, usually this is the heart attack patient who is hypotensive, right? So we need oxygen. We can't give them nitro because they're hypotensive. If we need to, we could give aspirin, and we're going to start an IV. It says large bore, and we can give a 250, 300 milliliter cc bolus here and see if it improves blood pressure. got to be careful. We don't want to overflow them in fluid. Definitely call for ALS. And you start giving some drugs to bring up blood pressure, but that's what the treatment is for that. Hypertensive emergency. So anybody that has a systolic greater than 160 or a diastolic greater than 94 is a hypertensive crisis. We're not going to use nitro to treat that patient because nitro is a potent vasodilator, and we don't want to drop that pressure too quick because that increases the chances of stroke. So someone who's in a hypertensive crisis, we're going to hold on that nitro and transport. I would go over some of these drugs, understand their classification and what their uses are. Aortic aneurysms. This is where your aorta becomes narrow, not very elastic anymore. If your systolic blood pressure increases enough, you could suffer a aortic aneurysm like this. So what they consider the diameter of the aorta increasing by 50% or more from its original size. Aneurysm, wider, greater than 3 to 4 centimeters. We have something called a AAA, an abdominal aortic aneurysm. Walls become thinner with a risk of rupture. Once the ruptures, survival is very unlikely. And the death will come from the uncontrolled hemorrhage. A lot of times being able to recognize that AAA is very hard. A lot of times these patients have lower abdominal pain. They radiate to the pelvis. They radiate to the back around the pelvis area. So it's hard to pick it up from a musculoskeletal injury versus a AAA. I would recommend looking at some of the risk factors to try to help you make a good clinical decision on this. You want to know what, these patients normally look pretty sick. Male, gender, usually someone of older age. They may have a history of bacterial type infections. Atherosclerosis is a risk factor. Smoker, someone with a history of hypertension. Maybe somebody who has a history of hypertension is uncontrolled. They're not compliant with their medications. Again, back pain. They may complain of abdominal fullness, vague gastrointestinal type symptoms. Sometimes you get lucky enough to feel a pulsating mass. I've never felt one in over 30 years of doing this. Instructor Lillard, or Bill, has done. He's actually told me he's had one that he was actually able to palpate. The key here is rapid transport. We're not going to fix this in the field. Start an IV while you're en route to the hospital, large bore. That's going to help get blood to the patient sooner if you have the IV already established. An aortic dissection is a tear in the tunica intima of the arterial wall. We can look at that right here. So here's the dissection right here. Tear the tunica intima allows blood to be forced between the layers of the aorta. Now, it's still inside the vessel, right? But this is where you get that ballooning to occur. If that external part of the tunica external ruptures, and you're going to have a massive hemorrhage, blood could leak into the pericardial sac, causing that cardiac tamponade. The treatment here is obviously airway management, IV. Heart rate disturbances. So anytime you have someone, the normal heart rate is right 60 to 100. So bradycardia can cause hypotension. Remember, cardiac output equals heart rate times stroke volume. If the heart rate drops below a certain number, and it kind of depends on the patient. Like I've had, and you may have seen this before too, athletes with pulse rates of 48 and they're perfusing great. But I've had adult males at 48 who had no blood pressure. So it just kind of depends on the person. They need cardiac drugs, but again, you can fluid bolus them in order to hopefully increase preload in order to get the heart rate up. Tachycardia is the same way, right? Usually when we start looking at someone in the 150s, 160s, we call that paroxysmal supraventricular tachycardia. It gets to the point where the heart rate can be so high that we lose blood pressure. Oh, that's it. That's the chapter. All right, we talked about a lot today. So I'll post this. We have the next chapter, which is neurological disorders to cover. I'll hopefully get that done in the next day or two. All right. Enjoyed it, and I will see you guys in class.